That's the thing I like about you.
So, good morning. My name is Adrienne LoPresti. I am the Associate Director at Yes Community Counseling Center. You may see on the workshop descriptions that Jamie Bogenschutz was supposed to be here. I apologize. I'm here on her behalf as she could not be here today. So today we are going to be having an overview of suicide prevention. Of course, it is a very, very broad topic. So hopefully we can send you home with some resources as well. So first, I just want to get a very quick sense. How many are here working in the capacity of a school counselor, either a social worker, psychologist, guidance counselor? Okay, many people. Great. What about anybody in a clinic environment? Very good. Other school administration? Great. Some administrators. Okay. What else do we have? What else? Who did I mention? I got everyone? Oh, all right. So let me ask, how many of you have encountered a youth, a student who was suicidal? Okay. Lots of hands. So I guess what I would say to that is we all have encountered somebody who's been suicidal. When we look at the statistics, we know that unfortunately, with the skyrocketing rates, that there are kids walking around us every day that fall somewhere in that continuum. They may not be acutely suicidal, but they may be in some place on that continuum of having thoughts at some point in their lives. So there's many things that we certainly can do as professionals. But certainly, we are all encountering students. Just yesterday on the news, there was, I don't know if everybody saw that at Westbury, there was an individual who was intercepted at the Westbury, I think it was the Gallery Mall, who attempted to jump from the top of the building. Just yesterday at Massapequa Park train station, somebody successfully completed suicide. So it's happening more and more around us than sometimes we even hear on the news. So some of the statistics that we will just briefly go through quickly is that each year 44,000 Americans die by suicide, and for every suicide there are 25 attempts, and suicide is the 10th leading cause of death in the United States, and men die by suicide 3.5 times more than women, but women attempt 3 times more than men. And on average, there are 121 suicides occurring a day. That number is probably higher now. And approximately 12 people attempt for every death. The rate of suicide is highest amongst middle-aged white men in particular. And firearms account for more than, or about 50% of all suicides. Also, I should just mention that the rates of suicide in the last 10 years have been up for women 60%. And up 28% for men, and just in the last 10 years alone. So according to the Center for Disease Control, they had a study that they conduct every 2 years. So in 2015, 29.9 students nationwide felt so sad or hopeless for 2 weeks or more that they stopped doing usual activities. And 17.75% of students nationwide had seriously considered attempting suicide. And 8.6% attempted suicide 1 or more times. 2.8% attempted to the extent in which it resulted in injury, poisoning, or overdose that was treated by a doctor or nurse. So when we're looking at risk factors, of course, we see these risk factors around us every day. Certainly, if we have a therapeutic relationship with a student, these are some of the things that, of course, we should be assessing in advance if we have contact with a student that we're concerned about. So, for example, if a student presents to us because they have social issues or are struggling some way academically, these are all the other areas that we want to take a look at so that if in fact there are greater risk factors or indicators of possible suicidality, we know what the risk factors are in advance. So one of them being genetic predisposition. We know that if a student has a parent with mental illness, they are at much greater risk for also having a mental illness and perhaps being suicidal. The family dynamic. So students who maybe be in a family where there is marital discord, parents who aren't home. We certainly hear this more and more at our program. We are an outpatient treatment program, and regularly we have parents calling for their children because they're concerned about them. And just in trying to schedule that initial appointment is incredibly difficult for these families. So a mother who's saying that maybe the father is working from morning to night, or there isn't another parent in the household, and that mother is holding two jobs. So who's with that child? Where's that parent-child contact throughout the day? There really is none. Abuse or trauma, and of course, sometimes that abuse can be covert. So it's not something known to us, or the child has not disclosed that they've witnessed, let's say, domestic violence in the home. Socialization issues with their peers, limited or no connection or relationships, school failure, lack of perceived lack of resources, previous attempts, of course, and history of depression. For those who complete suicide, about 50% or more have had a previous attempt. So that's certainly a very serious indicator when we know that someone has attempted. So what is different for our youth today? We know, as I had just mentioned, the family environment is changing. We know that depending on the demographics of the students we work with, many live in households where there are other family members charged with taking care of them. Lack of parent connections because of all the stressors and responsibilities that everyone has today. Everyone's overscheduled. You know, there's not one family to talk to that isn't carting their kids off to one activity and the next. So it's just really autopilot doing and a lack of real quality connection that's occurring. Social media, of course, which you may have already heard about this morning, and a decrease in real hands-on relationship. So we know also with technology that kids who are relying more and more on their phone or Facebook, Snapchat, gaming to interact with peers. And you see that a lot on play dates, right? Where kids are getting together, or if you observe a group of kids, and what are they doing? They're all on their systems playing games right next to each other. That's how they are connecting with each other. It's not real human connection. And of course, availability of alcohol, prescription drugs, and the prevalence of it today, that's certainly creating greater risk factors. So just a little bit with LGBTQ youth. We know that for LGBTQ youth between the ages of 10 to 24, suicide is the leading cause of death. And LGBTQ youth are 4 times more likely to attempt suicide and experience suicidal thoughts or engage in self-harm. For the general population of young people, 15 to 24, suicide is the 3rd leading cause of death. Okay, and homicide and accidents are more common. So in 2015, firearms were the most common method, which has historically been the case, and suffocation and hanging been pretty much the second cause at 26.8%, and poisoning at 15.4%. We certainly know with the increased rate in overdoses that sometimes it's difficult to determine whether drug overdose is intentional or not, and there's a really fine line, right? So when someone is addicted and feeling hopeless, there certainly may be passive suicidal attempts at ending their addiction through overdose. So that stat is probably not as clear as we would like it to be. Some other important trends regarding substance use is that suicide is the leading cause of death for those who have an addiction, and 25% of individuals who die by suicide were intoxicated at the time of their death, and alcohol was involved in 64% of attempts. So we know that that is the vicious cycle, and for our youth who may be depressed, may be anxious, and may be relying on substances, it is a vicious cycle because they're relying now on an external chemical to uh, boost their dopamine, their serotonin. And what happens when you remove that chemical or when they're withdrawing? There's a dip, right? So now they're even more depressed or more anxious than they were before they took the substance. So what do they need to do but take more substances to alleviate those effects? And it's the vicious cycle that leads to more depression, more anxiety, more symptoms of trauma, and increased likelihood for suicidality. If anybody has any questions or thoughts, please feel free to raise your hand. I'm going quick here. So gambling is another one. That's something that we know is prevalent in the school pride surveys. We certainly see it come up that students are reporting gambling, but that is really the last thing that we hear, right? That no one's really coming to us saying, hey, I need help. I have a gambling problem. And with our students, it takes shape in different ways. They're not maybe heading off to the casinos and even maybe on the internet, but a lot of it is gaming related. And a lot of it is also with counterfeit goods. So students who are accessing, trying to make money by buying products on the internet and then selling them for an increased cost. And sometimes those products get seized and now they owe everybody money. So, or things like that. We're hearing that at our program. So certainly something to be aware of if you see students that have access to a lot of high-end products or are selling things, really there's a gambling type of components to that. Just to mention a little bit about the elderly, rates certainly rise with men and significantly after the age of 65. And men over the age of 65 are 7 times more likely than females to commit suicide. And approximately 60% of elderly patients who take their own lives see their primary care physician within a few months. So that's another important thing to just consider that we have had at our program referrals from private practitioners in recent time who conducted a screening at a well visit for the students who reported to them symptoms because, quite frankly, no one has ever asked them the question because they didn't necessarily present with risk or indicators. So that's certainly a wonderful thing if we have relationships with primary care providers to ask them if that's something that they do, or to ask parents if that's something that they're aware of. Because we've certainly worked with parents that are shocked that their child returns with positive symptoms for suicidality, and that's the first place that it's come up. Women, ER visits for women and suicide attempts due to pain relievers have increased and are about 30% right now. Rates of women and opioid addiction have increased the highest amongst any demographic population. So that's climbed over 100% in recent years. So women who are taking pain relievers or started with pain medications are at much higher risk for suicide, and also due to chronic pain, trauma. These are things that are an indicator for suicide. So taking a little bit of a closer look at the warning signs and risk factors. Generally, when someone is suicidal, they do present with warning signs. Sometimes we might not see it, and it really depends on the proximity that we have with that person. So for a family member, they might not really see that because they're around the person so much that they're not in tune to the signs. They're not able to look objectively at their child. And for us, it really depends on the relationship we have. So in a school setting, let's say, as a clinician, it may not be us that becomes aware, but it may be their coach or their teacher that they're closest to, which is why, of course, that coordination of care and talking to everybody who is connected to a student who may be at risk is so important. Many years ago, in the early 2000s, I worked with a student who committed suicide in a clinical capacity. He was 17 years old, and clinically, he was showing no signs at that point because we know that with suicide, usually there's ambivalence, and then there's a part of somebody who wants to live. Well, I believe that this student had much less ambivalence and much more intent because he covered his tracks in every possible way he could. There was really nobody in his life that could say in hindsight that they saw it coming because he didn't want anyone to stop him, it felt. However, after the fact, in exploring, the one outlet that the student really was connected to was artwork, was art. He was a tremendous artist, and his art teacher came forth with a very descriptive picture that he drew of a big, tall clock and a noose and other things that were very, very dark and grisly and telling that no one would be drawing pictures like this if they were not thinking about suicide. But unfortunately, at the time, perhaps the teacher didn't really think anything of it because she didn't know about all the other things. She didn't know he was in counseling. She didn't know that there were previous signs of aggression. So we are charged with such a difficult task that sometimes what we see in front of us is just not enough. And we have to pull in everybody in that student's life to see how we put all those pieces together and have a better sense of what may be playing out. A little bit more about the warning signs. They may signal a suicide crisis if students present with these symptoms. And sometimes it's not the acute crisis, but they're starting to have thoughts about suicide. So feelings of hopelessness, anxiety, agitation, trouble sleeping not at all, or much less of the time. So, a student who's tired in school, oh, I don't know what just happened. So a student who may come to you and tell you that they're not doing well in school because they just can't fall asleep at night and they're up half the night. So clearly that's an indication, not necessarily that they're suicidal, but that they're struggling emotionally and they may have a very high level of anxiety that they're not even aware of. Of course, expression of having no reason for living or no purpose in life. So for kids who are even graduating and they don't have a plan and they really don't know what they're supposed to be doing, that in itself, again, not a risk factor, but coupled with some other things could be. We mentioned agitation. So for the student who's impulsive and maybe acts out aggressively towards others, that's certainly an indicator of internalized of rage that we need to take a look at. Feeling trapped, like there's no way out of their situation, and increased use of alcohol or drugs. Some more withdrawal from friends and family. I mentioned rage, uncontrollable anger, reckless behavior, or more risky behavior. So sometimes we see kids who are passively suicidal, so they're just doing things that make them more accident prone, getting into car accidents, doing things that might injure them, or really are impulsive, lack of judgment, and lack of concern for their well-being. And of course, giving away prized possessions and dramatic mood changes and thoughts, intentions, or a plan, something posted on social media. And of course, that goes along with us having to educate other students that if they see something, simply trying to reassure the person that things will get better is not going to be a solution for that person in that moment. They need to intervene with an adult who can help that person. So I don't know if any of you guys have ever seen this. Is PATH warm? Has anybody ever seen this acronym? Yes? No? Okay. So what I would suggest, the reality is no matter how many times you conduct a suicidal assessment, you are likely to be anxious and overwhelmed, or it's stressful when you have someone in front of you who might possibly be thinking of taking their life. So there are a lot of tools out there, and through SAMHSA is one of them. And everybody familiar with SAMHSA? Okay, great. Substance Abuse Mental Health Administration. And so it's, I have to look it up, SAMHSA. So they have a treatment protocol. It's called TIP 50. And there's a brief guide all about suicide intervention. And there's now even an app. So you can look on your phone under SAMHSA Suicide Safe, and it will walk you through all the steps of conducting a risk assessment. It takes you through some of the possible scenarios and discusses documentation. Yes? Sure. It's SAMHSA, SAMHSA, Suicide Safe. And so there's TIP 50 protocol, and there is the app so that you can access it on your phone at any time. And I've even heard of some clinicians that will open it up at the time of their assessment and say, I just need to ask you some questions, and I'm going to use this tool so I make sure I don't forget anything. For some, if that's what you need to do, what's important is that you touch on all the key areas. So some of the things that we're looking at, again, is path warm, which we had just mentioned. Some of them is ideation, substance abuse, purposefulness, anxiety, trapped, hopelessness, withdrawal, anger, recklessness, and mood changes. So the more signs that are present, the possibility of a higher risk, but it also is possible that we may see a few of these present and the student is still at risk. But this is good to keep in mind and available through the SAMHSA tips or the app. Just quickly, let's see what time we got here. Okay, going through how suicide occurs. Of course, often there is an underlying mood disorder, anxiety, aggression, impulse control, and then a stressful event. So sometimes that's what we fail to, or I should say, speaking with other clinicians that I've supervised, that's the part where maybe we get tripped up, where we become like the suicide police, asking questions, firing questions out there, when we really need to slow down, listen, and really understand for the student or the youth what is going on, what led them to feel like this was their best option without any reservation or judgment. Because if we rush to try and undo what's happening for that student, how are they going to feel? Unheard. Absolutely. And if you talk to any suicide survivor who's been helped and you ask them why they didn't do it, very often they'll say, because somebody listened. And I've heard from so many people who've said that somebody saved their life, and it wasn't because they were convinced not to kill themselves. It was because someone simply heard them and understood why their pain was so great and how difficult their circumstances were. And that brought the connection to them and feeling like, okay, I'm not alone in this. So it's just so important that we do what we do best and listen and take the time to not rush to, okay, now I have to get this person to not want to kill themselves, because we're missing the most important piece, which is understanding what is going on for this person. Why is their pain so great? And what is their triggers? And are these triggers ones that we can look at solutions, or are these things that are persistent that may not be going away? And what are the alternatives? What are the coping skills that we can offer this person? So the other thing that we see after a stressful event, which may be a breakup with somebody, ongoing academic failure or underachievement, involvement with the law, getting into serious trouble at home. What are some other things? Humiliation, public humiliation, and certainly through bullying, that's something that we see enough of. That's often some of the precipitators. And then the acute mood change. And from that point, if the person has strong feelings with a taboo against committing suicide, other coping skills, and we can slow them down, then hopefully we can get to a place where that's not there are alternatives. But for some, if they have a weak taboo against suicide where they're not concerned about what that means to them, they don't have religious belief, they're not concerned about being the wrong thing, and there's access and impulsivity, we have less time. So GATE is something that also you'll find on the Suicide Safe app, and a very common protocol. And as you can see, sounds pretty simple, right? But it's really a matter of making sure we take all these steps. So if we think somebody is potentially suicidal, the first thing is to gather information. And what that means is we have to ask the question. And we can't be afraid to ask the question because we are not going to make anybody commit suicide by asking them if they're suicidal. And we have to make sure that we say it clearly. So we're not saying, are you thinking of hurting yourself? We have to ask it clearly. So what's the question that we ask? Are you suicidal? Yes. Are you thinking of killing yourself? Or to say, sometimes somebody in your shoes, what you're experiencing, might feel like they want to end their lives. Are you having those thoughts? So we have to ask the question. And if we don't, that might be an indicator to the person that we're really not comfortable talking about this. Also, open-ended questions. So not saying things like, you're not thinking about killing yourself, are you? Now, that might sound silly, but to a newer clinician, that's something that someone might say. And really just asking questions that lend itself to a conversation. Rather than trying to get down to the information that you want to obtain, to really have a interactive conversation that's not just about firing off questions. And again, the listening, which means understanding and validating. So once we ask those questions, on the next page we will get a little bit to the lethality piece, or maybe actually, I'll go to that and then I'll come back. So if the person, we know the questions we always want to know is if they're having thoughts, how vivid those thoughts are, how frequent those thoughts are, and if they have a plan, and if they have access to the plan, and what precipitated. Those are the 4 key pieces, but within those questions, we need to ask more, right? So did they consider any other ways of coping? Did it work for them? Has anything like this happened in the past? We have to take the time to ask those questions, and how elaborate the plan is. So if there is a plan, I would just use a gun. Okay, do you have a gun? Do you have bullets? How would you get it? Do you have money? If they want pills, where are they located? Where else might you get them if you couldn't find them there? So we really have to make sure we have a very clear sense of what are the details of the thoughts that the person may be having. And sometimes, of course, we're not going to get all the information, but the other thing that I would say, because I think we all get stuck in the gray area times where the student, they're saying they have thoughts, they're not really saying they have a plan, but when they said it, they hesitated to us. Now what do? We don't want to overreact. It's the end of the school day, or the parent's working. Doesn't matter. We have to encourage parents and have a plan to take that child for an inpatient evaluation at an ER. And I can't stress that enough, because there are many times where I've heard where we just get lost in that, where we're just not so sure what to do. And if we're not sure, of course, the first thing that we do is we have to consult with a supervisor and hope that, or consult with another colleague, but to ensure that we do make sure that they receive medical help and view this as any other potential medical emergency, right? Because if we send them to a private psychiatrist, if they have one and they're available, that's great. But more than 9 out of 10 times, there's not going to be a private psychiatrist available, and they're going to have to go to the ER. So having a list of those resources, making sure that we get a release and we call in advance and say, you know what, I'm just going to call them in advance to let them know that you're coming, because a lot of times the risk factors that we're aware of, the family may be minimizing, right? Because they're just in denial or in shock, or they're just not, at this point, they're not aware of how serious the issue is. So I'm sure that some of you have interacted with parents who say things like, oh, I know he just says that when he gets angry. He would never do it, though. So we have to make sure that parents understand the seriousness, and that we call the ER in advance and say, these are the things that we're seeing, and this is why we're concerned. because they might not hear that from the youth or the family member. Okay. So taking appropriate action, that's one piece is, of course, sending a youth with a plan to the ER. But another possibility is if we're finding that, and we wholeheartedly are comfortable and believe that there is not a plan present and thoughts are fleeting and they're not present in the moment, and we can come up with an alternative plan. We need to have a thorough plan, and we need to take the time to do that. Contracts are no longer recommended, so I don't know if anybody uses that term anymore, but a contract like sign this and say you're not going to kill yourself. It feels more like a liability to the person sitting across from you. We don't want that. So I have in the front of the room a safety plan that is research based and has been used throughout time and replicated in many different ways, that is basic, and you could amend that to your own. But you really want to take a look at, hold on, let me just make sure let's see. Okay. Who they're going to contact during a crisis. What are the supports that they have around them? Who are the people in their home that they can go to, or extended family members? People in the school building. What are some of the warning signs for that student that they know that they're going to be hitting their peak, or where they're feeling over the edge? What is that going to look like for them, and who are they going to speak to? What are their internal coping skills? What can they access within themselves? So there's a lot of different pieces to it. And then if in fact they are suicidal, what are the 24-hour supports available, including 911? So everybody involved with that student or that youth needs to have access to this. And we know that, do you have a question? Is that through Northwell Health? Okay, so that's part of the outpatient Cohen's, I believe. Yes. Okay. So that's excuse me? That certainly is a wonderful alternative, less intimidating for families, right, who don't want to go to the ER. For some, I think for most insurances, though, that shouldn't be an issue, right? Okay, so that's all Medicaid and terrific. Yeah, so that's an extension of Northwell and Cohen's. It's just more of an outpatient than an ER environment. But Cohen's also has their child psychiatry ER, right? As does Stony Brook. And there's a couple of other, some of the hospitals provide telepsych ERs, which aren't, of course we know NUMC has outpatient psych. So there are resources, and certainly, we just tell families, like, be prepared to wait. But we also sometimes need to let parents know, which is a really, really hard thing to say to a parent. But, the alternative, you are responsible for ensuring your child's safety, and to not do this, to not take your child in what is considered a medical crisis is considered neglectful. And you may need to tell them that I may need to call Child Protective Services because I'm a mandated reporter if we don't ensure your child's safety. Or to give the parent the option, if they say, I don't think I could get them there, well, we can call an ambulance, and they can also take them if that's easier for you. And I know, that sounds crazy, but some parents may prefer that if they're concerned their child's going to get volatile. We also know the mobile crisis unit, the Child Mobile Crisis Team. Is everybody familiar with the Child Mobile Crisis Team? So if you have a child that you're working with who can't get into you at school or in your office, and you can call, and if they're not functioning and you're not sure if they need an ER and they need an evaluation to determine that, that is another good resource. So of course you need to have your list of all these things. The other thing that I would mention is that often it's so important we work as a team. So it's wonderful if we sit down with our colleagues and decide together what tools are we using and so we're all speaking the same language. What is it that we're most comfortable with? So there's the Columbia Suicide Rating Scale. Is everybody familiar with that? That's great because they have a short scale and a more thorough scale. And if you just Google that, Columbia Suicide Rating Scale, they have a couple of different research-based tools. I have the short scale up here in the front along with the safety plan. So that's something that is just a quick, like, covering your bases, making sure you got through all the important pieces. That's something that I would discuss with your colleagues and see what everybody is most comfortable using so that the process just seems a little bit more quick and detailed. The other piece that I would mention, of course, is documentation. So it is so critical so when we're communicating, let's say when we're leaving for the day, that those that might encounter the student know what's going on, and for our own liability and protection, that we are as detailed as possible about what it was that we heard, what were the risk factors, and what steps we took, and what is our role, what we're going to do next, and what the parent was instructed to do, so that, and what are the other alternatives. So 911, 24-hour hotline, cover every single base we have and make sure it's as thorough as possible. What are some other pieces I just wanted to mention? I think about documentation. Oh, just that it's also really important that we keep in mind that, as we know, when a youth is suicidal, that sometimes when they come to us, they might not say that they're suicidal, and we might ask directly, and they'll still won't tell us they're suicidal. But we have to use our gut and work with them and develop a plan, even when there's not the presence of a plan, or the thoughts aren't being reported, because child who present with a high level of stress may also evolve into having thoughts. And on the other end, when the acute crisis is over and the child is maybe discharged from the hospital and returned to you, that doesn't mean they're no longer suicidal, right? It just means that it's no longer acute, and it's likely that they're going to continue to have thoughts and require very, very close monitoring and a plan that you're reviewing with them at all times. So that's, again, you might have to pull in some other staff to be checking in on that student, because it is very time consuming, and sometimes we need to stop other things that we're doing to ensure we have the time to go through a thorough plan and assessment with the student. So we have about 10-15 minutes left. I was wondering if anyone wanted to share what has been, like, why you came to this workshop. What was the most, what in your experience has been most difficult about working with students who may be suicidal, or the obstacles that you faced? Yes? Good point. That's a lot of times that's what we're seeing, right? The gray, not where it's definitive that this person is overtly suicidal. So, is that what you guys see a lot? Kids who are reporting fleeting thoughts, but not necessarily having a plan. So it's like, okay, what do we do now? Yes. And unfortunately, it appears like we're going to be seeing this more and more in this day and age, right? Because the rates are showing that depressed teens and teens who are suicidal are skyrocketing, and we know that this is largely due to technology, right? So we have kids who are overstimulated, overscheduled, and have less of a threshold because they have not learned to self-soothe, yet the stress in their lives are greater than it was, and they don't have that same human connection. So that certainly turns into depressive symptoms and possibly suicidal ones. And it is really challenging because when we're trying to maintain the relationship with our parents, we don't want them to feel like we're overreacting, and we don't want to send every child to the emergency room because they're having thoughts. So where's that line? And I think the best thing that we could do is really make sure we take the time to ask all the questions. So if we know that they're having the thought, how detailed the thought is, when do those thoughts come up, how frequent are the thoughts, what happened before the thought, what happened after the thought. So to really make sure that we're comfortable asking so many questions, so at least we can be sure in ourselves, to the extent that we can be, that, well, I have really spent so much time finding out that this student, this is maybe a piece of the picture, but there's so much more to that. We need to know what surrounds all those thoughts. And sometimes, again, we're narrowed in on the suicidality that we miss the bigger picture. So to really spend the time, what are their coping skills? What are they doing after school? Who's going to be there with them? What will they do next? And bringing the parent in. So sometimes it really is about spending time, ensuring that that parent can get to you and discussing with them everything that we know, and remembering that at that point we can't rely on confidentiality. We need to have those conversations and be very clear with the parent. I mean, that's my feeling, that sometimes a child might say to us, please don't tell my parent. They're going to be so upset with me, and maybe there's abuse going on at home. So what do we do with that? But we can't hold on to that information, and we must let parents know clearly and directly that your child is having thoughts of killing themselves, and this is what those thoughts look like, and they need help. So being as thorough in our questions and speaking to parents are very, very important, in the documentation piece. And with that, now that we have a walk-in clinic, there's an easier option. And sometimes even just asking them to go to their pediatrician is another safeguard. I find that the pediatricians that are skilled, and all of them should be, in asking those questions, sometimes they might have relationship with the student or the parent in a way that will engage them and reinforce the concern, at least, rather than it ending in your office. Other thoughts or questions? No. What tool is everybody using now? Are you using a tool, or it's just from your experience? Shout it out, girls. Experience? Okay. Okay. And does that work? Yes? Mm-hmm. Mm-hmm. Mhm. That's all they feel they have. Mhm. There's a lot of discussion about that. Certainly, is self harm, does self harm or self injury correlate with suicide? We know that they're not one and the same, and that many choose to self harm because it's an outlet and release, but they have no intention of dying and they do not want to die. But certainly, there's another example that we need to ask those questions, right? Because somebody who does self harm may also have want to die, and it's okay to ask that question, and we don't know unless we ask the question. Yes? Yes. I hear you. Yes, and we do need to wrap up, but that's a very good point that if a child has a negative experience at the hospital, they might not share in the future. So, what do we do with that? And we need to continue to remind them that there's help available and ask them directly what, if there was an alternative to you going to the hospital, might I know more about what's going on for you? Can we talk about those alternatives and try and engage them? And it's all about the connection. It's all about staying connected. But you're right. Thank you very much. We're going to wrap it up. Have a good day at work.
It's just the thing I like about